all of you in this conference, which I wish all the success. In culmination of the sincere efforts of the organizing committee, especially Professor Dr. Iman Sha'rawi, Dr. Naveen Gado, and Dr. Dina Salim. And now we will start the session of gastric cancer. Let me introduce our first speaker. Professor Dr. Thorsten Goetz, Germany, Senior Consultant in Charge and Deputy Medical Director of the Institute of Clinical Oncology and Research and Clinic for the Oncology and Hematology in the North Frankfurt main hospital, and I think, if I'm not wrong, he was a participant in FLOT4 and the Keynote 585 trials. Okay?
in Frankfurt, Germany. My talk will focus on recent landmark trials in esophageal gastric cancers. Here are my conflict of interests. So first, focus security situation. The question is, why is periodic treatment proposed in gastric or GE junction cancers? Because normally the tumors are clearly resectable. Problem is that disease recurs in at least 40 to 50%, and 40% of metastatic patients had previous curative gastrectomy. In the curative situation, we have to discuss the highlights from 2021 regarding an extended adjuvant IO therapy and the head-to-head comparison of chemoradiotherapy versus perioperative chemotherapy. This slide reflects the current situation in the therapeutic landscape of gastric as well as GE junction cancer. There are the following perioperative concepts. First, neoadjuvant chemotherapy followed by surgery and adjuvant chemotherapy possible for gastric and GE junction adenocarcinoma. Second, neoadjuvant chemoradiation for GE junction adenocarcinoma as well for esophageal squamous cell cancer. And third, pure adjuvant chemotherapy, what was not so common in the Western world but in Asia. Let's start with cross, neoadjuvant chemoradiotherapy for GE junction adenocarcinoma as well as esophageal squamous cell cancer versus pure surgery alone, with a remarkable benefit for chemoradiotherapy group compared with surgery alone. This table shows the former landmark trials, 2 chemotherapeutic trials, MAGIC and ACCORD, and the one mentioned cross chemoradiotherapy trial. If you have to look in the subgroups, the British MAGIC trial for gastric, British MAGIC trial, gastric cancers are predominating, comparing chemotherapies ECF and ECX versus pure surgery alone. Survival benefit is 13% for chemotherapy. And in the French Accord trial, GE junction cancers are predominating, comparing chemotherapy with cisplatin 5FU versus pure surgery alone. Survival benefit is 13% for chemotherapy. And the mentioned cross trial, including a mixed group of esophageal cancers with adeno and esophageal squamous cell cancers. A sufficient part of the MAGIC and Accord patients had GE junction cancer, and this population showed the greatest benefit. So chemo is sufficient in GE junction cancers, the most debated region versus chemoradiotherapy. CROSS was a quite small trial with only 366 patients. Regarding the complete pathologic response, the complete path response was 49% for squamous cell cancer and 23% for adenocarcinoma. Demonstrated by the dotted arrows in the graphic, the benefit regarding overall survival was highest in the squamous cell group, comparing chemotherapy versus pure surgery alone. If we have a deeper look in the data, in patients with N+ disease, there was no significant benefit because in our eyes, chemotherapy is a more local treatment with no real systemic effect. Also, the benefit for adeno subtype was not significant. In addition, only 69% of pure surgery group had an arterial resection, reflecting on insufficient surgery in the standard of care arm. This is a FLOT4 trial design. 4 times FLOT neoadjuvant and 4 times FLOT adjuvant compared with a strong comparator with the former standard ECF or ECX and not pure surgery only, in a quite big trial of 716 patients. Regarding OS, FLOT was able to show an OS benefit of 45% after 5 years compared with the former standard of care ECF or ECX with only 36%, exactly the percentage like in the MAGIC study. So ECF and ECX has not underperformed. And as you can see by the forest plot, FLOT was able to show efficacy in the diffuse type signal ring cell cancers and showed the best OS in GE junction type 1 cancers. The majority of patients in FLOT4 were in GE junction cancers. And as you can see here, 56% of patients in FLOT4 were GE junction cancer, with a total of 398 GE junction cancer patients. So in FLOT, there were more GE junction cancers than in the whole CROSS study. In sum, FLOT was able to nearly doubling 5-year overall survival compared with pure surgery alone in the former older trials. So as I promised at the beginning, 2 current new trials in 2020 and 21 dealing with the problem of chemoradiotherapy. CheckMate 577 was nivolumab after CROSS in patients with extremely important residual pathological disease, so a quite negative selection for patients without complete path response. The data regarding DFS and PFS showed a significant improvement for adjuvant nivo after incomplete response to surgery plus CROSS. As you can see here, the positive effect is definitely more pronounced in the squamous cell group and especially in patients with a positive PD-L1 score with CPS5 and more. The NeoAEGIS trial shown at ASCO 2021 was not a landmark trial, but a head-to-head comparison versus FLOT or CROSS, or indeed it was a comparison of chemo versus CROSS, because in the human only 27 patients received FLOT and 157 patients received the MAGIC regimen. And to make a long story short, CROSS was not superior to the old MAGIC regimen, and MAGIC, as I've just shown, was definitely inferior to FLOT. Or FLOT is definitely superior to ECF and ECX. So quite important head-to-head study in my eyes. Data from Keynote 585, chemo plus minus pembro in the same situation are weighted. And the big global Matterhorn study of Astra for FLOT plus minus durvalumab has just finished recruitment last week. And we have shown the interim analysis from Dante phase 2 trial, FLOT plus minus atezolizumab with an improvement of downstaging path response due to adding checkpoint inhibition. And this was even more pronounced in the PD-L1 positive situation. So proceeding with the palliative situation. The CheckMate 649 was first shown at ESMO Europe 2020. It was a randomized phase 3 study comparing standard of care chemo, FOLFOX or Xelox, plus minus nivolumab. At ESMO 2021, second arm of IO only with Nivo, low dose and high dose EP was also shown. Starting with chemo plus Nivo arm. 60% of patients had CPS 5 or more within the trial, quite high. There was an OS benefit for CPS 5 and in all randomized patients. So nivolumab, the addition of nivolumab was approved by EMA for CPS 5 cohort. And also there was a PFS benefit. Quite interesting, in MSC high, there was a median overall survival of nearly 40 months. But as you can see by the arrow, chemo only was not detrimental for the MSI high compared with the MSS patients. We have shown our data from Moonlight at ESMO 2 weeks ago for chemo plus Nivo and Ipi in a sequential or simultaneous treatment situation. The trial was negative for the sequential application. But very interesting, Moonlight, as well as shown, Dante already shown, showed that PD-1 positivity is less common than 60% of CPS5, as shown in a 649 CheckMate study, reflecting more or less, I think, the real-life situation. CheckMate 649, Nivo plus Ipi versus chemotherapy arm. First-line adenocarcinoma. No benefit for IO only, and PFS was even half of the chemo data. But extremely potent combo for MSI high in my eyes in this population. CheckMate 648, Nivo plus chemo versus Nivo plus high dose, Nivo plus low dose, Ipi versus chemo alone in squamous cell esophageal cancer only. Nivo plus chemo showed an OS benefit in all randomized patients and especially in TPS 1 or more than 1. Here's the forest plot, shows no real benefit for PD-L1 negative according to TPS or even in the exploratory cohort CPS. Same effect in the Nivo arm. Here are the corresponding overall survival curves for Nivo and EP. And if you have a look at the PFS of IO only, it was not superior to TPS and even inferior in all randomized patients. So currently it's not clear which patients are the right patients for chemo plus Nivo or IO only in squamous cell cancer. At ESMO GI this year, was associated with delayed onset of effect of IO only relative to Nivo plus chemo. But as you can see, all overall survival curves in one graph here shown, there was even a slightly better OS for the IO only combo compared with the other two arms. Keynote 590, esophageal cancer, adeno as well as squamous cell cancer, chemo plus minus pembro. And according to the curves shown there was an approval for the addition of pembro to chemo for ESCC and adeno with CPS 10 or more, according to EMA. At ESMO GI this year, the global rational 306 study has shown data for chemo plus minus tislelizumab. Interestingly, the backbone of platinum 5FU was possible and backbone of platinum and taxane. And patients were tested with Ventana SP263, not with the Daco stainer. To make a long story short, addition of tislelizumab improved significantly PFS and OS. And PD-L1 negative in PD-L1 negative and positive, but the score used was different from CPS or TPS and more similar to a TAP score, as shown example given in BTC cancers. Maybe soon also in addition of pembro to standard of care chemo plus trastuzumab will be a new standard of care for HER2 positive first-line patients, and it's already approved according to the FDA. Landmark trials in second-line settled ramucirumab mono or in combination with paclitaxel as standard of care, according to the data of REGARD and RAINBOW trial. Destiny Gastric 01 established trastuzumab deruxtecan as a second-line option in the FDA region for HER2-positive and is advised by the NCCN guidelines. It's not approved by the EMA. And at last but not least, TAX established TAS 102, so-called LONSURF, as last-line standard of care monotherapy in gastric cancer patients. So I thank you very much for the invitation and wish you a nice congress.
Thank you, my dear doctor. Any questions from the audience? Any questions? So, Dr. Thurston, I know you have participated in the FLOT4 trial and Keynote 585 trial, and I have a few questions for you. Regarding the FLOT4 trial, there is some criticism in the interpretation of this of its results. As you know, only 37% of the patients completed the course of ACF in the post-operative phase, compared to 50% in the FLOT arm. Second criticism is the pattern of administration of 5-fluorouracil in both arms was not equivalent. As you know, in FLOT arm, there is a high dose for 1 day continuous infusion. In ACF, it was 200 milligrams daily continuous infusion for 6 months. It is known that the pharmacokinetics of the 5-fluorouracil alters the mechanism of action. How can we neutralize these parameters to interpret the overall survival improvement?
Yeah, it's quite easy to declare because ECF and ECX has not underperformed. It's perfect in the line with the old MAGIC trial. So, and in MAGIC, not all patients proceed with adjuvant treatment. That's quite common within the adjuvant trials. It's like also example given in the Dante trial, the FLOT8 trial. We have shown at ASCO currently with atezolizumab. That's often the fact, but the main fact is that the ECF, ECX exactly show exactly data like in the MAGIC trial. So there's no underperformance. And on the other hand, the administration of FLOT is not similar example given to Folfox. It's more, we call it, if we give only FLOT without taxane, we call it flow, because there is only 24-hour administration for these patients with a higher dose of 2,600 compared with 2,400. It's extremely effective and it's very, very well tolerated, although in the palliative setting. So example given often also used from example in templates or something from BMS that they say example given according to Checkmate 649 that is approval for nivolumab plus 5FU and platinum-based therapy, and platinum-based therapy can be Folfox, can be flow, can be FLOT. So I think FLOT and flow is quite accepted in the Western world, and so this is I think not a debatable standard in this situation. And we have a lot of forthcoming trials. We have shown Petrarca trial with very good data, phase 2 data for the addition pertuzumab trastuzumab with extremely high response rate, published in the GCO 8 weeks ago. And now we are going to publish the ramucirumab trial, RAMSIS, in combination with FLOT. And yes, and the next one is maybe published in Nature is the FLOT8 trial.
Okay, another question, please. What's your opinion about the role of radiotherapy in the neoadjuvant session? I know the Top Gear trial, its result hasn't been published yet, but what's your opinion?
Yeah, that's a quite hot topic. I think chemoradiotherapy in the neoadjuvant setting, according to Cross, is definitely a standard. It's more or less a standard for squamous cell cancer, as I've shown you, and it's more or less problematic that we have a good adjuvant treatment after cross with nivolumab. It's perfect data. The curves are definitely separating early, and there is a long line of the curves, but it's only for patients without complete response. And I've shown you that a lot of patients have N+ disease without a real benefit, and the adenocarcinoma have a quite small benefit in this situation. So in cross, you have not a sufficient part of systemic therapy implemented, and the local control is not the problem in the later situation, because nearly all patients with gastric or G junction cancer will die on the metastatic seeding.
My final question will be about macrocytic instability, high status tumors in gastroesophageal junction. Are you with or against the chemotherapy in this category of tumors?
Yeah, we use this chemotherapy. We know these data, example given from meta-analysis from Pitti Antonio in combination with the classic trial on all these trials. And they have shown that there's no benefit for MSI high patients adding chemotherapy. But as I have shown you in the palliative setting, the two trials, 649 and 648, chemotherapy is not detrimental compared with the MSS patients on the one hand. On the other hand, we have shown at the FLOT8 trial that MSI patients are very, very well responding on the FLOT regimen. There's therefore a clear votum for perio of treatment with chemotherapy in the MSI situation, and even adding a checkpoint inhibition is even definitely more potent in this situation.
Thank you very much. Any question from the audience?
Thank you, Dr. Thurston. And my question is, in spite of a considerably good objective responses obtained in the preoperative setting of whatever treatment is, yet the recurrence rate is still considerably high. Do you think this can make a rationale of a protracted post-operative treatment as a sort of maintenance treatment beyond the chemotherapy with another modality, either target therapy or immune therapy, in a protracted maneuver or protracted regimen? Do you think this rationale may make a difference?
I think yes. I think 577 checkmate has shown that nivolumab in the adjuvant situation after cross pretreatment and surgery, there is definitely an effect in these patients, especially in patients with PD-1 positivity. And I think in the other one too, because we have doubled the overall survival rate with FLOT compared to surgery alone, but nearly 50% of patients still are dying on gastric cancer after in a curative situation. And this is definitely an option that all patients have to proceed with an adjuvant therapy, I think. And in my eyes, the not good responding patients to FLOT or whatever, that are the patients not the ideal candidates for chemo after surgery, but the good responding patients with a PCR of 1, according to Becker exam 1A, with a complete path response. These are especially good candidates for proceeding with chemotherapy, and maybe in addition of other substances.
Thank you. Thank you, sir. Any other question? Thank you, Dr. Thompson, for your presence and the presentation. And now we will move to the second speaker, Professor Ahmed Gaballa. Ahmed Gaballa, Professor of Clinical Oncology in Shams University, GI Unit. And his talk will be in the metastatic gastric cancer, how to optimize your treatment. Welcome, Dr. Ahmed.
Thank you, Dr. Khalid. Thank you, Professors Organizing Committee, for this invitation to give this lecture. Today, I'll present the updates. I'll give the topic of metastatic gastric cancer, how to optimize the treatment. I think there will be an overlap in some slides with Professor Thurston's presentation. This was the ESMO guidelines in 2013, considering the treatment of advanced and metastatic gastric cancer. The standard treatment for HER2 positive was trastuzumab in combination with platinum fluoropyrimidines, and for HER2 negative was platinum combinations whether duplets or triplets with fluoropyrimidines. This only if the patient can tolerate the treatment, and if the patient in a bad performance status, usually we give the patient best supportive care and no active chemotherapy for these type of patients. And we have only one option for HER2 positive patient based on the TOGA trials, which was trastuzumab with cisplatin, fluorouracil, or capecitabine. And this was in 2013. I now present the recent data considering the HER2 positive metastatic advanced gastric cancer. This was the imminent TOGA trial, which was published in 2010 in Lancet 2010. These data showed the comparison between chemotherapy versus chemotherapy with trastuzumab in advanced gastric cancer HER2 positive overexpression. And we have overall survival benefit in HER2 expression, and this benefit was higher in patient with immunohistochemical analysis of +3 or FISH positive patients compared to chemotherapy alone. Based on this trial, trastuzumab combination was the standard of care for a long time as a first line for metastatic gastric cancer. Recently, we have the data from Keynote 811. This data was presented in Nature 2021. The Keynote 811 was comparing pembrolizumab plus trastuzumab, fluoropyrimidines, and cisplatin compared to placebo trastuzumab chemotherapy. And the overall survival and the progression-free survival was the dual primary endpoint for this trial. And we have also the overall response rate. In this trial, we have a significantly higher overall response rate in patients with advanced metastatic gastric cancer to pembrolizumab arm compared to the trastuzumab chemo alone. We have a difference in response rate of 22.7%, 74% compared to 51%, which is a very big margin of benefit in the overall response rate in the first interim analysis in this trial. We have previous data of overall response rate for anti-PD-1 only treatment of 11%. But with trastuzumab chemotherapy, the response rate reached 74%. Later in my presentation, we will have the data from the Checkmate 649, which showed that the difference of adding immunotherapy for this group of patients was only the difference was 15% if the patient has combined prognostic score high. But here we have a difference of 22.7%. Difference in the response rate of adding pembrolizumab to the trastuzumab chemotherapy arm. We still, the results for progression-free survival and overall survival is still pending. We didn't have the results yet, but based on this eminent response rate difference, the FDA accelerated approved pembrolizumab in combination with trastuzumab chemotherapy as a first line in HER2 positive metastatic advanced gastric cancer in May 2021. What about the second line trials for patient with HER2 overexpression metastatic or advanced gastric cancer? We have a lot of first line trials like Jacob trial of adding pertuzumab to the combination of trastuzumab chemotherapy, and this trial was negative. And we have the logic trial of lapatinib with Xelox combination compared to Xelox chemotherapy alone, and this trial also was negative. So for first line treatment, we have only the trastuzumab or the trastuzumab immunotherapy as a first line. For the second line, we have a lot of trials. The Titan trial of lapatinib paclitaxel, and it was negative trial also. Gatsby trial of TDM1 compared to paclitaxel alone, and there was no survival benefit of TD1 over the paclitaxel arm. And we have the T-ACT trial of adding trastuzumab to paclitaxel beyond the progression after failure of trastuzumab, and also it was a negative trial. So for second line, the anti-HER2 therapy in gastric cancer was not of a big add value for patients. Later, we have this new molecule. This is the Gatsby trial of TDM1 compared to paclitaxel, and the two curves are identical in the overall survival. Based on this, TDM1 is not approved as a second line in gastric cancer. But then we have this immunoconjugated molecule, which is trastuzumab deruxtecan. Trastuzumab deruxtecan have a lot of approvals in breast cancer, and now it has approval in gastric cancer. It is a humanized anti-HER2 IgG1 monoclonal antibody linked to a strong anti-chemotherapy deruxtecan. Deruxtecan is a topoisomerase inhibitor. It is more potent than the TDM1. It has a high drug antibody ratio of more than 8. A stable linker payload, tumor selectable cleavable linker, so more concentration of the chemotherapy inside the tumor cells, high potency and membrane permeability, and it is very strong and potent chemotherapeutic agent, the deruxtecan. We have the Destiny gastric 01 trial. In this trial, they randomized the patients between trastuzumab deruxtecan, and the second arm was the physician's choice of chemotherapy, whatever the second line chemotherapy chosen, which is irinotecan or docetaxel or paclitaxel. And the patient continued treatment until progression or unacceptable toxicity. The primary endpoint of this trial was overall survival, and the secondary endpoint was progression-free survival and overall survival. Actually, the trial was positive for patients. This trial has two population groups, the Asian population and the Western countries population. The trial was positive in both populations with overall survival ratio of 50% compared to 14% for chemotherapy. And we have an overall survival significantly higher in the trastuzumab deruxtecan treatment versus chemotherapy, with hazard ratio of almost 0.6, which means that 40% reduction in death in this population. Also, we have a progression-free survival benefit of more than 50% reduction in the progression and failure of the treatment. In this trial of note that 30% of the patient during recruitment in this trial had a new fresh biopsy after progression on trastuzumab therapy. 30% of the patient only obtained a new biopsy after progression. And we found that the patients with higher response rate usually positive in the second biopsy. Higher level of circulating microRNA of estrogen receptor, epidermal growth factor receptor 2 in the circulating plasma by microRNA or circulating DNA. If the higher ratio in the plasma, it reflects in the response rate. Tissue microRNA of more than 9.7 has a higher response rate also of 80% compared to 23%. Based on this, FDA urges the physicians to rebiopsy and retest the HER2 after progression on trastuzumab therapy, because we have almost 20% of patients lose the HER2 expression after progression on the trastuzumab therapy in the first line in metastatic and advanced gastric cancer. And also this analysis from the Destiny Gastric 01 trial confirms that you can use circulating DNA as a surrogate marker before starting the treatment if the tissue biopsy is not available. We have also Destiny Gastric 02 trial of trastuzumab deruxtecan in HER2 advanced and metastatic gastric cancer. After failure of trastuzumab, this was an open-label phase 2 trial, and it confirmed also the overall response rate. And the secondary endpoint of progression-free survival and overall survival was confirmed of benefit. In the gastric Destiny 01 trial, most of the patient was in phase 3, in third line of treatment after failure of trastuzumab, not in second line. In gastric 02, it was in a second line setting. Based on these trials, the FDA granted approval for trastuzumab deruxtecan as a second line in the States and at the third line in Japan. There is other selected trials of immunotherapy in combination with anti-HER2 in HER2 metastatic and gastric and advanced gastric cancer. One of them is trastuzumab, is Destiny 04 trial. Destiny 04 trial. They are comparing second line of ramucirumab paclitaxel versus trastuzumab deruxtecan. The result is still awaited, and we have the tucatinib trial in combination with trastuzumab, and we have the Destiny 3 trial of trastuzumab deruxtecan with immunotherapy and chemotherapy. All these results of this trial is still awaited. We'll go back for the first slide, which is the treatment of gastric cancer in 2013. We said that in patients with HER2 negative, the standard was platinum fluoropyrimidine, whether triplet or duplet combinations. And now we have a lot of changes in the first and second line setting in this group of patients who are HER2 negative. We have the imminent checkmate 648 trial of nivolumab in combination with platinum chemotherapy as a first line advanced and metastatic gastric and esophageal adenocarcinomas. The trial composed of 3 arms of nivo chemo versus chemo, and we have a third arm of nivo epi as a combo immunotherapy alone. These slides was presented with our colleague, Professor Gutza, in the previous talk. We found that there is a statistically significant difference and benefit of patients receiving the immunochemo combination compared to the chemo alone if we have a PD-L1 expression of combined prognostic score more than or equal 5%. And this was highly significant with a hazard ratio of 0.68. In this trial also, we have benefit in overall survival in the patient with high combined prognostic score of 5 or more, and the hazard ratio was 0.71%, means that there is 30% reduction in death in this group of patients. And also, we found the same benefit in patients with PD-L1 combined prognostic score of more than 1. But it is not highly significant. The highly significance was in the PD-L1 more than 5. In the nivo-epi arm compared to chemotherapy, actually there was no benefit in both progression-free survival or overall survival compared to chemotherapy alone. So based on this data of CheckMate 648, now the standard of care for patients with HER2 negative advanced or metastatic gastric cancer, the chemo-nivo combination is the standard of care if the PD-L1 expression is 5 or more. What about the MSI high gastric cancer? We have data from the 648 trial. It was an interim subgroup analysis comparing the nivo-epi combination compared to chemotherapy alone. And actually, there was a statistically significant difference and benefit for patients with MSI high tumors of dual immunotherapy compared to chemotherapy alone. And we have also the data from Keynote 62 trial of pembrolizumab, whether alone or combination with chemotherapy compared to chemotherapy alone. And the pembrolizumab, whether alone or in combination with chemotherapy, has a higher benefit on overall survival in MSI high population. So what about other targeted therapy as a first line in metastatic and advanced gastric cancer? We have a lot of negative trials of bevacizumab and cetuximab, panitumumab, relutumab. All these trials were negative. What about the second line in these patients with HER2 negative? We have strong data that second line chemotherapy in this group of patients is better for overall survival and progression-free survival. We have a lot of data. One of these trials is a Cougar trial comparing docetaxel versus best supportive care as a second line in gastric cancer, and it has a better overall survival. What about second line therapies for HER2 negative patients? We have the Granite trial of everolimus single agent compared to best supportive care, and this was a negative trial. And then we have the famous Regard trial of ramucirumab as a single agent compared to best supportive care. Sorry. And in the Regard trial, there was an overall survival benefit of ramucirumab alone. And we have also, sorry. And we have also the Rainbow trial of ramucirumab with paclitaxel compared to best supportive care, and both showed a better overall survival in as a second line. The future direction, we have the FGFR2b targeted, the bemarituzumab with chemotherapy compared to placebo chemotherapy. If the patient is overexpressing the FGFR2b receptor, and this was a positive data in the fight. This was a phase 2 trial, and the phase 3 trial is still awaited before getting the FDA approval. We have also the Claudin 18 isomer 2 expression in gastric cancer. It is almost expressed in more than 80% of gastric cancer patients. And we have the zolbetuximab with chemotherapy EOX combination. It was a positive trial in phase 2 FAST trial, and still the phase 3 Spotlight trial is awaited before getting the approval of anti-Claudin therapy in gastric cancer. For the third line, we saw this slide with Professor Goodze about TAS-01 as a third line or salvage in refractory gastric cancer, and it was a positive trial. Based on this is the summary of first line of metastatic and advanced gastric cancer. Usually recommend to test HER2 first, and if HER2 positive, go for trastuzumab combination or pembrolizumab trastuzumab combination. If HER2 negative, test MSI and the combined prognostic score for PD-L1. If you have the combined prognostic score of 5 or more, give nivo chemotherapy based on checkmate trial. And if the MSI is high, you can give immunotherapy, pembrolizumab in combination with chemotherapy, or dual immunotherapy, nivo-epi as a first line. If the combined prognostic score is low or PD-L1 negative or MSI is stable, so go for chemotherapy alone, doublet or triplet. For second line, we strongly recommend retesting the HER2 after progression on trastuzumab therapy before going for second line. And if HER2 is positive, so better to give the patient trastuzumab deruxtecan. If HER2 negative and the patient can tolerate chemotherapy with good performance status, ramucirumab with paclitaxel as a second line has a very good overall survival. If the patient performance cannot allow, you can give ramucirumab as a single agent, or you can give chemotherapy, whether irinotecan or docetaxel as a second line. And this special situation for third line and specific genetic alteration of FGRF or Claudin 18 isomers presentation. Thank you.
Now, floor is open for discussion, and I will begin with my question about the daily practice, how to deal with the challenge and obstacles when treating elderly patient with metastatic gastric cancer. Do you go for dose reduction, supportive treatment only, single agent systemic therapy, or what you do?
Yeah, if the patient performance status can allow the systemic, usually we depend on the performance status of the patient more than the age of the patient. So if the age of the patient is high and the patient performance is good, yes, we go for the standard treatments. We test for HER2 and we test the PD-L1 MSI. and we treat according to this. But if the patient performance status cannot withstand the treatment, usually we put the patient in best supportive care and we don't give active treatment. So the key point for elderly patient is the performance status and the comorbidities in these patients.
Thanks, Professor. Any question? Yes.
For those patients with advanced gastric cancer with a new era of treatment, many of the patients achieve CR. When do you recommend or do you go for local management for those patients after achieving CR? Or very good partial response with a residual amenable for local management? When do you consider local management for those patients?
Actually, until now, we don't have data about the local management of metastatic or advanced gastric cancer after systemic control. We have a small set of data about patients with metastatic gastric cancer who achieve a marvelous or good response locally, and we have a small residual resistant metastasis, like, for example, Krukenberg tumor as a residual after good response systemic in the gastric or stomach itself. In this group of patients, we have a small set of data recommending going for local surgery for a localized metastasis, but we don't have a strong data of doing this. This is not a standard of care, and we don't have survival benefit till now. So we don't have that.
Dr. Ahmed, from your practical point, do you believe in maintenance with trastuzumab after response to aiming to delay second line?
Sorry?
Maintenance by trastuzumab. Maintenance after response and alone as a single agent to delay second line.
It will depend on the tolerance and toxicity to chemotherapy combination with trastuzumab. If the patient is tolerating, usually you continue with the combination trastuzumab chemotherapy. If the patient has acceptable toxicities and can tolerate the treatment. But yes, if the patient has a toxicity from chemotherapy, yes, you have a point. You can stop the chemotherapy and continue on anti-HER2 therapy alone.
Thank you so much.
Regarding the keynote 811, do you recommend to add pembro to in HER2 positive advanced gastric disease? Do you recommend to add pembro to trastuzumab chemo or trastuzumab chemo alone without the need of pembro? And any rule for PD-L1 scoring in this population?
In the keynote 811, actually the benefit was in all population, not depending on the PD-L1 expression.
When you decide to add pembro?
We have the FDA approval of using this combination in the States only. In the EMEA, they still not approving this that. So if your patient can tolerate the combination of anti-HER2 chemotherapy and pembrolizumab, yes, you can give, and if you have insurance coverage for this. I know you have the insurance in your hospital.
Any other questions? Thank you, Professor Ahmed. I would like to introduce the next speaker, Professor Salamid, Professor of Medical Oncology at NCI Care University. Is going to be talking about optimal multimodality treatment of localized esophageal and gastric cancer.
Bismillah ar-Rahman ar-Rahim. Dear Chairman, at first I'd like to thank Ain Shams University Oncology Department for the kind invitation and make me part of this meeting. I think it's hard task to cover such hard topic, which is the optimal treatment for localized disease. Why? Here are my disclosures. And as you know, we will cover today esophageal and gastric cancer, but as you know, gastric and esophageal cancer remain a major cause of cancer-related deaths. For adenocarcinoma, exactly, surgical treatment is the main treatment or the curative modality, but unfortunately, up to half of the patient will relapse after surgery. How can we improve on after curative surgical treatment for those patients? You know that failure may be related to local treatment, so we may need local recurrence, so we may need radiotherapy, or systemic recurrence, so we may need systemic treatment. as you know here, recurrence, mainly either local or distant, rely mainly on the initial stage of the disease. With the higher stage, we expect more recurrence. Further, even the subtype of the stage, if you have just one step higher in the stage, you expect more percentage of recurrence. But the problem, we have a lot of challenges when you are try to treat localized gastric and esophageal cancer. Why we have these challenges? Remember that we have a different anatomical sites. Remember that we start the esophagus from the neck as cervical esophagus, passing through the thorax, the thoracic esophagus, then the gastroesophageal junction with the Seward classification 3 parts, passing lastly to the gastric, the proximal gastric, then the distal gastric. So a lot of anatomical locations with different biology and different molecular classification. Also, there is different geographic approach in the management of gastric and esophageal cancer. We have the Asian, we have the American approach, and we have the European approach. And there is a lot of clinical trial with different eligibility criteria and recruitment of different patients. So this make difficult to draw a conclusion or clear guidelines for a specific part for the treatment of localized esophageal and gastric cancer. So how can we make this easier for the management for us? So I'd like to broadly classify those group of patients into 3 groups. The first one is the cervical esophagus, which is a squamous cell carcinoma, then grouping broadly the esophageal squamous cell carcinoma, and lastly, we group the adenocarcinoma either in the lower esophagus or the gastroesophageal junction or gastric as one group. You know that esophageal squamous cell carcinoma, including the cervical esophagus and the thoracic esophagus, mainly they are squamous cell carcinoma with 2 different parts. The first part with cervical esophagus, it's clear that concomitant or definitive chemoradiation therapy is enough. Surgery has limited role here, but it increased the problem, or the problem increased when we go through the squamous cell carcinoma of the thoracic part. If we have early stage, I mean T1 or T2 with negative lymph node, it is better to go for surgery. And if there is positive margin, we can add adjuvant radiotherapy. But if we have higher stage, more than T2 or any positive lymph node, we have a lot of approach, a lot and a hell of clinical trial, but try to make it simple here. We can start with preoperative chemoradiation and do a surgery, or we go for surveillance without doing surgery and put surgery as salvage. But if we started with higher dose, I mean definitive chemoradiation, it is better, and the patient achieved endoscopic remission or radiological remission, it is better to go for surveillance because we expected a higher radiological and endoscopic complete response. So we can decline surgery and make surgery later on as salvage treatment. Adjuvant radiotherapy, if you did surgery, was already given for patient with positive margin rather than. So this is for squamous cell carcinoma. I will not go for further details for squamous cell carcinoma rather than the slides. But the problem is with adenocarcinoma. Adenocarcinoma in the lower esophagus, gastroesophageal junction or gastric. This is a wide group of the patients. We have a lot of approach, a lot of clinical trial. As you see here, there is preoperative chemoradiation, perioperative chemotherapy, or start with surgery, then adjuvant chemotherapy, or adjuvant chemoradiation. Each one of these approach already has level 1 evidence to support this approach. So how can we choose? What is the evidence behind each approach? If we start with preoperative chemoradiation, I mean start with chemoradiotherapy followed by surgery. Here, the landmark cross trial, randomized patients, and this is for this group of patients, 1/4 of the patient included in this trial is a squamous cell carcinoma, and the rest of the patient are adenocarcinoma for the lower esophagus and gastroesophageal junction. Randomized patient to direct for surgery or concomitant chemoradiation using carbotaxol followed by surgery. Here, the initial results, showed survival benefit in favor of concomitant chemoradiotherapy compared with surgery. But the benefit mainly for the group of patients with squamous cell carcinoma. There is still benefit for adenocarcinoma, the main benefit for patients with squamous cell carcinoma. As you remember here, the median overall survival reached 80 months for squamous cell carcinoma, but only 40 months for patients with adeno. So there is a question mark. Patients with adenocarcinoma may need further management or other line of management. The updated analysis for this trial also showed consistent benefit after 10 years of follow-up, and also still there is major benefit for patients with squamous cell carcinoma rather than adenocarcinoma. But recently, the Checkmate 577 tried to improve on, because still, as Dr. Khaled said, still we have good percentage of patients who still have a recurrence, either local or distant. So adding for patients who did not achieve complete pathological response, randomized to receive adjuvant immunotherapy nivolumab versus observation. And there is here a clear benefit regarding disease-free survival in patients in favor of patient receiving nivolumab compared with observation. And the benefit mainly still with patient with squamous cell carcinoma rather than patient with adenocarcinoma. So if you have a squamous cell carcinoma, it is better to start with concomitant chemoradiotherapy followed by surgery or observation. But in adeno, we need to improve on this. The second approach is the sandwich technique, which is perioperative chemotherapy. And here, I mean, start with chemotherapy followed by surgery, then to give adjuvant chemotherapy. You have a lot of data here started by the MAGIC trial, which randomized patient to just surgery or to sandwich technique with the ACF protocol. Remember that most of the patient here was gastric adenocarcinoma, but there is 15% of gastric esophageal and some patient with lower esophagus. The results here in favor, sorry for this. I mean that I passed. I think yes, sorry. I'm not that good with this technique, yes. So the MAGIC trial, as mentioned here, there is consistent benefit for patients with adenocarcinoma with perioperative chemotherapy. And another trial which included more patients with gastroesophageal, as we know that there are lower percentage of patients in the MAGIC trial, but patients with gastroesophageal in this trial, French group with just cisplatin and 5-FU, showed the same consistent benefit with this sandwich technique. The FLOT4, with more intensification of chemotherapy in the adjuvant setting, showed good and significant benefit compared with the classic ACF protocol regarding the rate of resectability and the rate of R0 resection. And this was translated in significant improvement in disease-free survival and overall survival. Remember, with the cross protocol, we reached up to 40 months. And here we can touch the 50 months in the median overall survival with the FLOT protocol. This makes the FLOT protocol as a standard protocol for patients with adenocarcinoma. But now we have the preoperative chemoradiation versus the chemo, how to choose between both. We have two evidence. And the new Aegis trial tried to compare directly patient with adenocarcinoma with the cross protocol or the FLOT or the chemotherapy protocol, mainly the ACF, and the fewer of the patient included with the FLOT. There is here higher percentage of patient with pathological complete response in favor of concomitant chemoradiotherapy like the cross protocol, but unfortunately this was not translated into overall survival benefits. So ACF may be equal for this trial to the cross protocol, I mean preoperative chemoradiotherapy. But they did not compare the FLOT protocol with the cross protocol, and we are waiting for the Esobec German trial to solve this problem. Still, we have to improve on by adding the new targeted agent. And if we have HER2 positivity, the Betraca trial tried to add trastuzumab for the FLOT protocol. And the primary endpoint for this was the rate of pathological complete response. And the trial met its primary endpoint regarding the pathological complete response reached 14% compared with the classic flood protocol, which is 5%. So adding trastuzumab for patients with HER2 positivity for the classic flood protocol may improve outcome. We need to improve further, and we need a longer follow-up to assess the overall survival. Again, the ramucirumab was added also for the flood protocol for the same group of patients. They only increase the rate of R0 margin, but the trial was negative for the other parameters. What about the adjuvant chemotherapy? If the patient already started with surgery, is there any role for adjuvant or chemoradiation? I mean, if the patient here, the Japanese, which are the surgery, the standard of care front line here with D2 resection, try to assess observation after surgery versus S1 adjuvant, and they showed clear benefit in favor of the adjuvant cell-gate agent S1. More intensification with adding docetaxel compared with S1 showed also significant benefit in favor of overall survival. The Korean group tried to assess another protocol, which is the Zelox, compared with the observation in patients with only gastric adenocarcinoma stage 2 and 3, and also showed consistent benefit in favor of adjuvant chemotherapy. So surgery alone is not enough. So we now have 3 approved approach. What about adding radiation to chemotherapy after surgery? And this is the American approach. This is started by the older trial, which intergroup trial for patients who did D0 or D1 or D2 resection, randomized patient after surgery to observation or adding concomitant chemoradiation. There is consistent benefit in favor of the combination after surgery, but there is some criticism about this trial because half of the patient, most of the patient did not do proper D2 dissection. So may the gain benefit here just to improve the suboptimal surgery done for these patients. How can to assess the role of radiotherapy for such a group of patients? This is the question addressed by the ARCIS trial, which is patient who did proper D2 dissection and randomized for the combination chemotherapy alone versus the chemotherapy combined with radiation therapy, and they did a proper chemotherapy comparator, which is cisplatin capecitabine, rather than single agent in the intergroup. For this trial, it was negative and positive only for patient with positive lymph node, but patient with negative lymph node, there is no benefit. So the subgroup analysis here showed that only patient with positive lymph node or negative and the intestinal type. Still, there is a question about the role of adjuvant radiation therapy. So this is the question again addressed by ARTIS-2 trial. So they recruited patient with proper D2 dissection and has positive lymph node, and randomized patient to just single agent S1 or doublet chemotherapy by S1 and docetaxel. I mean more intensification of chemotherapy, or this doublet plus radiation therapy. And the trial came, single agent is not enough, inferior compared with doublet or trimodality treatment, but unfortunately here, the role of adding radiation therapy did not add benefit for the doublet chemotherapy. So there is some doubt about radiotherapy after proper D2 dissection, but we are in favor of intensification of chemotherapy rather adding other modality like radiotherapy. So now we have the 4 approach for, remember, this adenocarcinoma of the lower esophagus, gastroesophageal junction, and gastric. We have 4 approved approach: the preoperative chemoradiation, the perioperative chemotherapy, adjuvant chemotherapy, and adjuvant chemoradiation. So this is my final take-home message. Remember that in esophageal squamous cell carcinoma, if it is cervical esophagus, concomitant chemoradiation therapy, the definitive is enough, but the rest of the patient to give preoperative chemoradiation or even definitive chemoradiation to be followed by observation and keep the surgery as a salvage management in case of recurrence, or to be followed by radiation, the surgery is the standard of care, and we may give adjuvant nivolumab for patients who already have a residual disease. But in the adenocarcinoma part, either in the lower esophagus, gastroesophageal, or gastric cancer, the role of neoadjuvant and adjuvant is really evolving with a lot of agents added. So after D2 dissection, if you started with surgery, adjuvant chemotherapy significantly improved the disease-free survival and overall survival. The role of radiotherapy in such situation as adjuvant after proper D dissection is not that clear. But the preoperative chemoradiation in adenocarcinoma little bit need more discussion, but it is classically here the main benefit gained by patient with squamous cell carcinoma. Again, if there is still residual for squamous cell carcinoma or adenocarcinoma after doing surgery, we may do adjuvant nivolumab. The more appealing for me is the perioperative chemotherapy with the flood protocol, either to add other targeted like anti-HER2 for patients with HER2 positivity, significantly improve the outcome. Still, we need more with more agents like immunotherapy or targeted agents. They are promising, but need further investigation. Thank you for your attention.
Thank you, Professor Salim, for the usual very educative and clear
Thank you.
presentation.
On time.
Any questions? I just have, yes.
Salim, thank you very much as usual. Salim,
you.
you have shown that more is not necessarily better, like addition of Herceptin to radiation in multimodality therapy. In one study was negative. In the Petrarca study, it was positive. With addition of Herceptin Perjeta, we achieved higher pathological response. So it was the first study to show an improvement of a doublet anti-HER2 with chemotherapy. But however, this study did not move into phase 3 trial. Why do you think this was a good decision from the developer, or you think this was not fine to
Good
to
decision
stop it?
with what?
This was a good decision not to move this study to a phase 3 trial because we don't have an approval in spite that we got an initial signal of positivity from a phase 2.
It's very difficult because you have the main benefit for the flood. If you have a doublet like doublet, I think HER2 may add some benefit. I think the pathological complete response for me is promising. Still the curve, no wide range between both. I think we have to test because still 50% of the patient in gastric cancer still will relapse. Furthermore, I'd like to go for more details regarding the molecular subtypes rather than only HER2, because there is a lot of resistant mechanisms. Because if we add anti-HER2 in the TOGA trial, by the way, there is benefit significant, but still benefit. This is questionable, the role of anti-HER2 in gastric. They have a role, but still this role not that significant. Why? I don't know. So to go for phase 3 or not, I cannot answer this question, but from the metastatic and this neoadjuvant trial, it deserved. But from another point of view, I think we have to go for more personalized medicine. I mean, just to keep those patients with HER2 with more intensification, patient with MSI, like in the checkmate, like Nivo plus AB as neoadjuvant, to separate, avoid chemotherapy, because we may found some patient here with MSI who will not benefit from chemotherapy. So it is difficult. I'm with more precision medicine, more molecular subtype to have the greatest benefit from these modalities.
That's evidently that the value and the impact of the anti-HER2 in the metastatic setting is different from the locally advanced setting.
Yes.
And at the time of the release of the Petrarca trial, everybody was very excited. And it was going to move to a phase 3 trial. On the same time, we had the data from the metastatic setting, which was negative. So they stopped it from moving to phase 3, which was, I guess, which was stupid, because sometimes the impact here is not necessarily reflecting the impact here.
Yes.
Thank you very much, Sam.
Welcome.
Just one last question. For a take-home message, so we are faced sometimes a lot with patients who go for upfront surgery for gastric or gastroesophageal and are lymph node positive and locally advanced. So which patients would you add radiation to chemotherapy in the adjuvant setting? Which subtype of patients? Just as a take-home message.
Yes. If you did a proper D2 section and you have the ability to more intensification treatment, I mean to give proper doublet, the phase 3 trial comparing doublet versus doublet plus radiotherapy did not benefit. But this is an Asian trials. We cannot apply the Asian protocol for us because the different biology. So if the patient with lymph node positivity, I am with going to adding radiation therapy plus doublet chemotherapy. Why? Because it is here in the artist too, it was negative, the added value, but the used chemotherapy is S1 plus oxaliplatin. S1 is active like capecitabine, but the different patient population may reflect this. So I am in favor of adding radiation therapy. And also, there is subgroup analysis for the ARCIS trial, by the way, the ratio of lymph node positivity. If you have higher ratio, there is a good role for radiotherapy. Lower ratio, the role of radiotherapy is somewhat questionable. I did not mention this in the slide.
Okay, thank you very much, Professor.
Welcome.
I would like to introduce closed
Uh,
session. Session 1 is closed.
I think I have a comment about the comment of Dr. Tamer regarding Petrarca phase 2 trial. I think there was an early closure because the trial was powered disease-free survival events of 260 cases and closed at 170. Because I think, and they didn't report about the overall survival. From the statistical point of view, the power of statistics does not allow them to continue for overall survival results.
The overall survival was not the primary endpoint for the study, but the pathological TR, the progression-free and everything was the real endpoint. The developer, in spite of the positive data, they did not move because they had at that phase the data from the metastatic setting, which was negative. So they said it's better not to move. They stopped it. And we know that the value of the dual anti-blockade sometime in the metastatic is better than in the local advanced. They have different value and different impact. I would think it was more wise to move to a phase 3 trial to check on this dual, because we had a really higher CR rate and a higher pathological, a higher rate of achieving an R0 resection with the dual.
Thank you, Tamer. Thank you all my colleagues and chairpersons, and thank you for all audience. And now it's time to close our session. Thank you all.